Okay, I think we're good to start. And so welcome and thank you everyone for coming this morning to the BCEHS clinical rounds. Today we're going to talk about the new provincial pre-hospital trauma triage and destination guidelines. Just a couple of housekeeping items. This lecture is recorded, and I can see that it just started. And I have been receiving some emails about how to access this afterwards for people who are here and want to look at it again, or for people who didn't get a chance to come. So once we receive the actual video file after the recording, Joe and the paramedic practice team will post it on the BCEHS operations Facebook website. So that's the way that we've been doing things over the last little bit. When there's any change to that, we'll let you guys know in the future. But that's the current way of accessing the talk afterwards. So as most of you know, the guidelines were published on February the 1st. So the main theme of today's talk will be around major trauma triage. Just an overview of what we're going to go through in the next hour or so. We're going to review some basic trauma principles. We're going to talk about the actual guidelines themselves. We're going to talk about the importance of trauma documentation, the collection of data, what we're going to do with it, and how we're going to actually use it to create feedback afterwards. And then we'll leave a time at the end for questions and discussion. So there's no better way to start a talk than to just use a case and describe a scenario. So we'll build upon this throughout the presentation. So this is a trauma call. You're called to respond to a scene of a high-speed rollover accident at 120 kilometers an hour on the highway. So when you get to the scene, this is what it looks like. So we're just going to review some of the basic trauma assessment principles and management principles as well. Now, the basic trauma principles are taught through the ITLS course, so we're going to highlight on some of these principles today as a refresher. We're not going to go into everything in detail. But information on the trauma assessment management guidelines are all also available on the BCEHS trauma guidelines or treatment guidelines. So please refer to the TGs for the most up-to-date information. If you ever have any questions or need clarification for anything, a great resource is our paramedic practice leaders. So John Deacon, Ole Olson, and Leon Baranowski. You can contact them or email them at clinicalpractice@bchs.ca. Another great resource are your local or regional paramedic practice educators. So when you arrive to the scene, you initially conduct a primary survey. Now, the primary survey consists of a handful of things. So first, sizing up the scene, conducting an initial assessment, doing a rapid trauma survey or focus exam, performing any clinical interventions or critical interventions, and then making a decision to transport. So scene size-up is really important because it helps protect you, it facilitates a better assessment, and it helps you anticipate and prepare for any challenges as the call progresses. So standard precautions, so personal protective equipment to prevent any sort of exposure or infective materials, wearing high-vis gear, your helmets, evaluating the scene for any dangers, so potential dangers to you, your patients, or any bystanders. Looking at the number of patients. So is this a mass casualty incident? Do you need more help? So if there's more than one patient, do you need other crews? Do you need more advanced crews like ACPs or CCPs if you're an EMR or a PCP crew? You want to look at sort of the equipment that you think you need to bring to the actual scene itself. So do you need backboards, collars, pelvic binders, tourniquets, wound packing or management gear, airway gear? So make sure that you have a sense of that before sort of walking onto the scene. The last thing is an overview of the mechanism of injury. Now, why is this important? Mechanism of injury is really important because energy still follows the physics laws. Energy is neither created nor destroyed, only changed in form. So the kinetic energy from motion associated with transfer is usually transferred and absorbed by the patient. So as a result, the high energy from high risk mechanisms puts patient at risk for serious injuries. So we know that about 5 or 15% of patients after sustaining a high energy event, despite having normal vital signs and a relatively normal exam without any apparent injury, still exhibit severe injuries later on during examination. So always have a high suspicion and never be complacent when you see a major mechanism. So The goal is to complete your initial assessment and your rapid trauma survey within about 2 minutes, okay? If you identify anything that requires a critical intervention, you want to delegate that to either your partner or another crew so that you can complete the assessment in a rapid and systematic form. Now, you stop the assessment if one of the following things happens. If the scene immediately becomes unsafe. So if the car starts going on fire, something along those lines, then definitely stop, and we want one patient rather than multiple patients. Airway obstruction, cardiac arrest, or you identify a life-threatening bleed. So with your initial assessment, you're trying to get a general appearance and an impression. So looking at age, looking at sort of male, female, looking at how they appear to you, sick or not sick. So you're going to identify any sort of major injuries right off the bat or bleeding, and you're going to look at their ABCs. Then you're going to complete your rapid trauma survey, which is a look and feel exam. So a organized feel of the head and neck, the chest, the abdomen, the pelvis, the upper or lower extremities, and the back. You're going to complete a set of vital signs and also a brief neurological exam. So the goal of this is, if you're organized, to try to complete this within 2 minutes or less, because this will give you an overview of what the patient has in terms of major injuries and give you a sense of what needs to happen for the patient moving on. So I just want to quickly touch on critical interventions. Now, these are things that you want to do immediately for the patient at scene. So if they need an airway or a ventilation intervention, that needs to be done right away. If there's major bleeding, so there's an arterial bleed, that needs to be controlled right away. If you're an ACP or a CCP, if you suspect tension pneumothorax and you need to decompress the chest, that happens right away. If there's a flail chest or a sucking chest wound, that needs to be sealed and stabilized. So after that's done, we have to make a decision about transport. So do we do more things on scene, or do we load and go? And so these are the situations where patients should immediately be sort of scoop and run or load and go. If they have abnormal respiration, abnormal circulation, altered mental status, a potential for shock. So we kind of describe this as an abnormal chest exam, a tender or distended abdomen, any sort of pelvic instability, bilateral femur fractures. These are all potentials for shock, right? So these patients should be load and go, scoop and run. If there's a significant mechanism, or if the patient's just in poor general health. If you're ever in doubt, transport early. If you're going to transport early, as with all 6 patients, just make sure that you notify the hospital as soon as possible. This allows them to get ready so they can have all hands on deck, they can have the trauma team called, they can have all their equipment ready so that when the patient arrives, everything can be done for them. So once the decision is made to transport, then there are non-critical interventions that happen during transport. So this includes establishing an IV, giving them fluids or medications such as TXA, splinting and bandaging other injuries. Your secondary survey is then completed during transport. So the secondary survey is like a more comprehensive exam. So this is not just identifying the life-threatening and major injuries, but identifying all injuries. In major trauma, this is done during transport. But if your time from transport to hospital is short, you might not finish your secondary exam, and that's completely okay. What you do want to make sure that you do is an ongoing exam. So an ongoing exam looks at the patient's changing condition. So if they change in condition, you want to be aware of that. You want to be aware of their mental status. So if that alters or changes, you want to reassess their ABCs frequently. You want to reassess any previous injuries that you've identified that might be life-threatening. And you also want to reassess any intervention that you've done to see if it's actually done what you expect it to do. So that's a brief overview of a trauma scene call. There are a couple of key trauma principles that we also want to highlight as well. So we want to minimize scene time. So part of this comes from a quick assessment and a quick decision to scoop and run or load and go. We want to try to keep scene times down to less than 10 minutes. So that's the ultimate goal. Okay? You want to keep your patient warm. So, heat on in the car, blankets, warmed IV fluids if you're, in a place where it's like really cold, and you've got cold saline bags. If you can warm them beforehand, that's also a great thing for patients. You want to follow the SMR guidelines that we have for spinal motion restriction. If you're at all suspecting a pelvic injury, so either by pain or by mechanism, then to bind the pelvis. You want to control all aspects of bleeding, not just arterial bleeds, but slow oozes, because over the course of time, multiple bleeds, even small, can be catastrophic or very significant. You want to keep patients hypoxic, so providing oxygen as needed. IV fluids for resuscitation to mentation or perfusion. So the goal of this is usually about a systolic of greater than 90 in a non-head injury patient. TXA in the patient who exhibits shock, hypoperfusion, or has uncontrolled bleeding. And the caveat to TXA is that we want to give it to patients who are within sort of 3 hours of their injury onset. Airway management as per the AIM principles, and then for head injury, specific considerations such as a higher systolic blood pressure, so aiming for something like a systolic blood pressure of greater than 120, avoid hypoxia at all costs, and if relevant, getting their head of bed up to 30 degrees. So going back to the actual trauma call itself, you approach the scene, you see one patient. So with your initial assessment, as you look from your windshield, you sort of see it's a 50-year-old guy. As you approach him, it's a driver restrained with airbags deployed. He's complaining of chest pain, abdominal pain, and pelvic pain. When you look at him without having examined him yet, he looks unwell. He looks distressed, and he answers your questions kind of in a confused format. When you do your rapid trauma survey, he's protecting his airway. He's got a bruise on his forehead. There's chest pain to palpation, but nothing in terms of an obvious flail segment or any paradoxical breathing. There's significant tenderness to the abdomen on palpation. The pelvis is unstable. When you examine his long bones, there's no pain or deformity to his femur. And your brief or rapid neurological exam shows that he's moving ×4 to command, and you get a GCS of 13. So eyes open to voice, kind of confused, but again, moving ×4. Your initial vital signs are as follows. The heart rate is 130, so he's tachycardic. The rest rate is 28, so he's tachypnic. He's hypoxic as well, with an 88% saturation on room air. And he's also hypotensive as well, with a blood pressure of 80/40. So in this trauma call, you decide to load and go, and that's appropriate. So you apply oxygen to make sure that he's not hypoxic, to improve his saturations. You extricate him, put him in full SMR, immobilize his pelvis, and move him to the ambulance. So while he's in the ambulance, you go code 3 to your hospital, and you start an IV, you give him fluids, you start TXA, and then you notify the hospital. So that's an overview, or we've kind of reviewed the basics of trauma assessment, the management principles, and kind of shown that through the case as well. So I want to spend the next 10 or 15 minutes just talking about the new provincial pre-hospital trauma triage and transport guidelines. So this has been a work in progress over the last year, and it's developed as a collaboration between Trauma Services BC and BCEHS. It describes a decision-making framework for all pre-hospital triage and transport of major trauma that can be applied provincially. All of the information that is in this talk can be found on the BCEHS handbook. So just to show you where it is, if you log on to the handbook under treatment guidelines, and under either adult or pediatric guidelines, there will be a major trauma section, and new to the major trauma section will be trauma triage guidelines. And so the full PDF version of the provincial guidelines can be found in the provincial guidelines document tab, but the salient points for trauma triage in terms of the steps and criteria, as well as the general destination guidelines, are found in the other tabs there. So this updated provincial guideline actually builds on existing trauma protocols that have been in place in the past. But we've introduced 3 new concepts with these guidelines. The first is the concept of lead trauma hospitals. The second is standardizing a definition for major trauma throughout the province. And the third is integrating adults and pediatrics into the same algorithm. So in the past, trauma hospital, quote unquote trauma hospital, was traditionally used to describe tertiary referral centers. So these are traditionally described as sort of level 1 or level 2 centers. But we know that in our province, the main hospital receiving trauma in certain parts of the province aren't always level 1 or level 2 centers. So, but rather there's just a hospital or a designated regional hospital with trauma expertise. So we really want to acknowledge this and the work that they do. So that's where the term lead trauma hospital comes from. So lead trauma hospital was created to describe all hospitals in the province designated to receive trauma for the specific regional catchment areas. So this is in the document itself, but this is a list of all the lead trauma hospitals for the province. Now, of note here, all lead trauma hospitals serve as both adult and pediatric lead trauma hospitals, with the exception of Vancouver General, which is an adult-only LTH, and BC Children's Hospital, which is a pediatric-only LTH. But otherwise, all the other lead trauma hospitals serve both adults and pediatrics. So why is understanding, defining, and identifying major trauma important? So we know from studies that trauma patients who experience major trauma have a higher mortality when they're initially under triage to a non-trauma center. So the goal for us is to get all the patients with major trauma to lead trauma hospitals. So in the past, there were variations within regions in the definition of major trauma itself. The guidelines now standardize the definition of major trauma so that the practice and communication is consistent throughout the province. So paramedics practicing in various regions, so let's say you're based out of the interior, but you're doing an overtime shift, let's say on the island or in Metro, or vice versa, you're in Metro and you're going outside to do a shift somewhere else. The actual major trauma triage and the process and algorithm and guidelines should be the same. Okay, the only difference will be the actual destination that you actually bring the patient. But the actual trauma triage and the process to triage that patient is the same. And we'll go through this in the next couple of slides. So the term major trauma implies that patients are seriously injured, so they require critical attention. And again, we want to transport them to lead trauma hospitals. The criteria are based off of the guidelines for field triage of injured patients that were published by the US CDC in prevention in 2011, and they're actually used worldwide. We define major trauma as a patient who meets either physiological, step 1, anatomical, step 2, criteria, or has a major mechanism that puts them at high risk for serious injury, which is step 3. So step 1 in major trauma triage is to look at the physiological criteria. Step 1 is intended to allow for rapid identification of critically injured patients by assessing the vital signs and the level of consciousness. So we know that these indicators demonstrate a high predictive value for severity of injury, and patients who meet any of these criteria, again, should be transferred to the lead trauma hospitals. So your physiological criteria for adults are a systolic blood pressure of less than 90, abnormal breathing described as a rest rate less than 10 or greater than 30, or the need for ventilatory support, and an altered LOC, so a GCS equal or less than 13. In pediatrics, the vital signs are abnormal vital signs for age or need for ventilatory support. Now, it's always hard to remember what the actual normal ranges for vital signs are for the pediatric population. So if you're ever not sure, they're actually readily available on the BCEHS app on the handbook, so just refer to those. Okay, and for pediatrics, it's the same. So a GCS of less than or equal to 13. And just remember that there is also a pediatric GCS score, which is different in terms of specific criteria for eyes, verbal, and motor for pediatrics. So if you're unsure or need a refresher for that, it's also available on the BCEHS handbook and app. Step 2 in major trauma triage is to look at the anatomical criteria. So patients who have normal physiology, meaning that they don't meet step 1 criteria, so they have normal vital signs, normal level of consciousness, but have an obvious anatomical injury, are still at risk for clinical deterioration and probably need definitive surgical management at a lead trauma hospital. So patients who meet step 2 criteria, so step 2 anatomical criteria, should also be transported directly to a lead trauma hospital. So some of the anatomical criteria are any of the following: a suspected or identified open or depressed skull fracture, new paralysis or neurological deficits, a major penetrating injury, which is described as any penetrating injury to the head, to the neck, to the torso, extremities proximal to the elbow or knee, facial injury with potential airway compromise, 2 or more long bone or proximal long bone fractures, crushed, degloved, mangled, or pulseless extremity, amputation proximal to the wrist or ankle, chest wall instability or deformity, such as a flail chest, major burns, which are described as partial thickness burns greater than 20%, or full thickness burns greater than 10%, or 2% in the pediatric population, or any high-risk burn, which is a facial or airway burn, burns involving the eyes, neck, hands, feet, groin, or high-voltage electrical burns, and a mechanically unstable pelvis. So these are all the anatomical criteria. And if, again, these are identified, the patient should be transported directly to a lead trauma hospital. So step 3 in major trauma triage is to look at the mechanism of injury. So in patients who don't meet physiological, so step 1, or anatomical, step 2 criteria, but have sustained a major mechanism, they're still at risk for serious injury. That may be occult or in pathophysiological evolution. So again, we know that through studies, using or including mechanism criteria helps reduce under triage by about 25%. The caveat to this is we do acknowledge that there's going to be some over triage. And in trauma triage, we err on the side of caution. So we don't really want to be under triaging anybody because that definitely leads to mortality. We also don't want a huge degree of over triage, but we're willing to accept over triage at the cost of under triage. So studies show that on average, by including mechanism criteria, we have a degree of over triage by about 10%. So under triage reduced by 25%, over triage by about 10%. Every system is different. Part of the reason why this is important, and when we talk about sort of documentation and data, is to actually understand what our service actually has for over under triage and see if we can improve our under triage and reduce our over triage. The last step, although it's not in the definition for major trauma, step 4 is to consider any sort of underlying condition that may put patients at risk for severe injury. So that includes the elderly. The elderly are at risk for more severe injuries, even from minor trauma. Hypotension in the elderly, so we have a higher systolic blood pressure cutoff for elderly patients. So the cutoff is less than 110. Patients on anticoagulation, patients who are pregnant greater than 20 weeks because they may need care for both mom and baby. And pediatric patients, no matter where in the hospital, should preferentially be transported to a pediatric lead trauma hospital just because of the rarity of pediatric trauma and also the expertise that's required to manage pediatric trauma patients. So again, these patients, they may not necessarily all need to go to lead trauma hospitals, but they all probably require support services available at regional centers. So please refer back to your regional guidelines or just transport them to the hospital, either the lead trauma hospital or a hospital that's capable of doing a complete evaluation and providing timely treatment. So putting this all together, we now actually have a framework that includes adult and pediatrics in the same algorithm for trauma triage and transport. So I'm going to go through this algorithm and we'll highlight the key points. So starting at the top, in any trauma patient, if you're unsuccessful in terms of being able to manage the airway, so this means failure to maintain patency by any sort of means, then this patient should be transported to the nearest emerge for management. So they need that urgent airway management. If you can ventilate and oxygenate the patient, it's not a failed airway. So if you can adequately ventilate and oxygenate the patient, but you think that they need intubation, this patient still goes to your lead trauma hospital. They go to your nearest hospital when you cannot oxygenate and you cannot ventilate this patient. And the patient who has a traumatic arrest, the first thing to do is determine if it's a blunt traumatic arrest or a penetrating traumatic arrest. In general, patients with a major penetrating injury in cardiac arrest should be transported to a lead trauma hospital or the closest emergency department, preferentially the lead trauma hospital, if the time of loss of pulse and respiration to arrival to the hospital is less than 15 minutes. Now, there are some regional variations on this based on time, and so we'll go through some of the regional algorithms just to illustrate this, but the general idea is that if less than 15 minutes, to try to get them to the hospital. As a refresher, just for blunt and traumatic arrests, we do have the BCEHS traumatic arrest protocol, and that's also on the handbook as well. So moving on to the steps for major trauma triage, I just want to reinforce the fact again, and this might be a broken record, but major trauma should be transported to lead trauma hospitals. So in step 1, if they meet physiological criteria, you're to transport them to the lead trauma hospital or the pediatric lead trauma hospital. In step 2, if they meet anatomical criteria, you're to transport them to the lead trauma hospital or the pediatric lead trauma hospital. In step 3, if they meet mechanism criteria, then you're considering transport to the lead trauma hospital or the pediatric lead trauma hospital. Now, we acknowledge that there are regional variations to this. So their regional trauma guidelines will dictate whether or not patients or patients who meet major trauma may still initially be transported to the closest emergency department. And that's because the distances or times to lead trauma hospitals are just too great. Okay, so just review the regional guidelines to see what is relevant for you in practice. Now, if there's any situation where you're uncertain of where the patient should go, just call. So contact clinical call, contact EPOS. They will give you advice in these situations. So just to finish off the rest of the algorithm, this is step 4. So your judgment and the local destination guidelines will help you decide your treatment or your transport decision. And again, if you're uncertain, contact clinical call or EPOS. Now, if none of step 1, step 2, step 3, or step 4 are met, then transport to your nearest hospital as per regular routine practice. So going back to the trauma call itself, it's not a failed airway. This patient's breathing by themselves. Patient's not in cardiac arrest. And based on your vital signs, they meet step 1 criteria for major trauma. So the decision is to transport them directly to the lead trauma hospital. So I'm just going to take a little bit of time right now to look at some of the regional trauma guidelines. And for people on the distributed sites, just let me know if this doesn't work. It should work. So we're not going to go through this in minutiae or detail, but just to illustrate. So in Fraser Health, there's both a Fraser East and a Fraser West algorithm, with the border being sort of 264th Street. So if you can see in the Fraser algorithm, if patients meet if patients have a penetrating traumatic arrest, if they're within 15 minutes of Abbotsford, if they're in Fraser East, or if they're within 15 minutes of RCH in Fraser West, then they go directly to the emerge department for assessment. In terms of destination, so in Fraser, if you can get to RCH within 60 minutes, it doesn't matter if you're in Fraser East or Fraser West, you go to RCH. So that's the algorithm that's there. But otherwise, you're transporting to Abbotsford. So that's illustrated here. So both of those are lead trauma hospitals, but there's a time to determine whether or not they should go to RCH or go to Abbotsford. Okay, so the same thing for step 1, for step 2, and then for step 3, it's considering transport to either, depending on your scene time or your transport time. So the Interior has been working on their algorithms, and they're currently under review and going to be published shortly. And the same thing with the island. Northern has a set of sort of the guidelines published as well. And it's a bit more complicated in terms of the decision algorithm. Now, if you're within the Prince George or your lead trauma hospital sort of area, within sort of 15 minutes, then you're going to go to your nearest lead trauma hospital. But the difference within North is that there's a lot of distance to cover, and transport times are long. So some of this may be clinical decision making based on sort of what the patient exhibits in terms of their injuries and their physiological status. So if potentially you are a very short distance away from a hospital or diagnostic and treatment center, but a longer time away to a lead trauma hospital, there actually may be some benefit to go to the nearest emerge rather than going directly to the lead trauma hospital. So these are the conditions that are in the guidelines that are written here. So for people up in the north, if you have any questions about that, definitely contact either your regional director or any of the paramedic practice leaders or paramedic practice educators, and they can help you understand the algorithm a bit more. But if you're ever at all uncertain during a call, the easiest way to sort of manage that is just to call clinical call or EPOS. So if there's no message to get across outside of that today, is that clinical and EPOS are a great resource when you don't know. And in the lower mainland, it's split into sort of, or in Vancouver Coastal, it's split into sort of both the urban area and the rural area. Vancouver Coastal is the only health authority that still separates the adult and peds guidelines, and that's purely because that they actually have two separate hospitals, one that's directed specifically for adults and one specifically for peds, whereas everywhere else in the province, all the lead trauma hospitals are both adult and peds. So that's the reason why there's a separate algorithm for both of them. And then there's an algorithm for everywhere outside of the Richmond, Vancouver, North Shore area. So that includes the rural and remote, so your Sea to Sky, your Sunshine Coast, and that's there as well. So take some time to review them, especially for places that you work or intend to work. And again, if there's any questions, feel free to contact any of the medical directors or any of the paramedic practice leaders or educators, and we're more than happy to help you answer any questions or understand the algorithm and how it works. Okay, so just to round out the rest of this talk, I want to talk a little bit about trauma documentation, the data that we want to collect and feedback. So in terms of trauma systems evaluation, our current evaluation of the system is based on indirect indicators that are derived from your documentation, right? And it's pretty well established that accurate identification of injuries and expedited transport is associated with better outcomes. So currently how we measure this is that we measure patients who arrive for under triage. What we do is we look at a percentage of major trauma patients who arrive at a non-trauma center that require a secondary transfer to a trauma center within 24 hours. And that is kind of the indirect way to look at under triage. Now, in the last quarter, 3.9% of patients required a secondary transfer, and about 54% were identified as initially transported to the appropriate destination. So it's kind of flawed, if you can sort of imagine that. So if you're, let's say, up in the northwest part of the province, the old definition of a trauma center was a level 1 or a level 2 center. So going to Fort St. John, which is your lead trauma hospital, is actually the appropriate destination. And it's actually probably appropriate for that patient to be transferred out from Fort St. John down to VGH for definitive care. And so that's not actually an inaccurate or an under triage. That actually is the trauma system actually effectively working. But we're not really measuring that because we don't have the data to actually be able to tease out whether or not that patient was under triaged or not. So the same thing with the 54% that were initially transported to the appropriate destination. You would think that all patients with major trauma would be transported at a higher percentage, but if they're being transported to non-level 1, level 2 lead trauma hospitals, they're actually still being transported to the appropriate destination. So that number is also a bit flawed. So we know that we've identified a bunch of issues, and there's also an amount of uncertainty in terms of the data that we actually collect. So a combination of complete and accurate documentation. So we know that vital signs are only documented in major trauma patients 85% of the cases. So there's still 15% of cases that we don't have any vital signs for. Injury identification is a problem. Now, we used to base this off of paramedic impression codes because that was the only way that we'd be able to gather information. So if you have an impression code of major trauma, does that mean bruised knee, bumped head, and sprained ankle? Or does that mean massive head trauma, flailed chest, and a smashed pelvis? So we don't really know, and we weren't able to really sort of get the data from the actual very well because a lot of it is also through text. So in addition, there's actually no linkage between our records and patient outcome data. So we can't really figure out whether or not we adequately treat, we did the right thing because we don't know what happened to the patients afterwards. So this brings me to this point. So this is a continual collaboration that we've been working with TSBC on for the last several years, but more so in the last year as we developed these guidelines. So Trauma Services BC has a trauma registry for all major trauma patients in the province. So when a major trauma patient shows up to a hospital, that's recorded, and they have all the data. So that, in essence, is almost the gold standard for the cohort of patients having major trauma in the province. What we didn't have before is what we thought was major trauma. So our goal is now we want to identify a cohort within BCEHS that we say that, okay, these are major trauma patients. And then the goal is then to link these two. So when we would link these two, if we look at the left side, so if there are patients that we identify as major trauma, but they don't show up on the Trauma Services BC Trauma Registry, then maybe these are over triage. So now we'll be able to understand that. Now, if patients show up on the major trauma registry, but don't show up in our cohort, then unless there's something that's missed from either a data or administration thing, then this is under triage, right? And so the goal is to then also, knowing that this is the cohort of patients that we've adequately or appropriately sort of triaged, then to assess that as well. The goal is at some point, if we're here, to get them to look something like this. So a lot closer together where we decrease our over triage and decrease our under triage. So how are we going to do this? And so this is where the trauma documentation and the Siren system will help us a lot. So now with Siren, and this was rolled out on March the 5th, you'll be asked if a patient meets major trauma criteria for every encounter, similar to how you are asked on your PCR if the patient has had a cardiac arrest at any point during the event or the encounter. This essentially creates the major trauma patient cohort within BCEHS. So prospectively, as paramedics, you guys are going to be identifying which patients you think are major trauma based on the guidelines. So Siren also allows us to do a couple of things which is really neat. So one is we're able to now have a documentation form that's unique for the fields that we want to collect and that are actually meaningful for evaluation. So fields now in the documentation form now has specific selections rather than free text. So it makes documentation a lot easier. And we know that from other health quality literature and QI and safety stuff, that the documentation rate is a lot better when it's not free text and it's selected answers that we want to fill in, and also reduces the variability in terms of the response. The last thing is that we'll continue to, when this is in place, we will continue to build our relationship with Trauma Services BC. And so the cohort that we have at BCEHS, and once we identify all the major trauma patients within our cohort, they'll be linked with the Provincial Trauma Registry, and we'll be able to get patient outcome data for all of these patients. So we'll get performance indicators for guideline compliance. We can calculate our over and under triage rates. We can look at where patients were initially transported and whether or not that needs to be changed if we're over or under triaging sort of for injury. And all this stuff, again, the coolest thing is that we can measure this against patient outcome. And so by looking at this over the next sort of year or two, we can actually now objectively guide and optimize the actual system itself. So, transport times initially of sort of 60 minutes versus 90 minutes, we can answer those questions, right? So this is what you're going to see if you haven't seen it already. So you'll see the question in the Siren documentation right after the cardiac arrest question. So it's a mandatory question that has to be filled out for every PCR. So it's a simple question. Did the patient meet mechanism, so either anatomical, physiological, or high-risk mechanism for major trauma? If you select yes, then it'll go to the Siren major trauma documentation form. So this is in with the other forms like the airway form, the fast fan scores. It's all in the same area. The cardiac arrest forms. It's all in the same area. So we want all these fields to be mandatory because there should be an answer to all of them if you clicked yes. If the patient has sustained major trauma, you should have an answer for all of these. Whether or not it's identified or none, there still should be an answer. The only one is the incident or date and time. So we kind of want to know when the date and time of the incident is, because then it allows us to go back and sort of take a look at TXA use and other stuff like that, and actually sort of look at time of injury to then time of definitive care as well. So The first question is, did the patient meet physiological criteria for major trauma? So that's step one. So the answer is either yes or no. If the answer is no, then moving on to the next. So major trauma injury suspected. So that's step two, your anatomical injuries. Just note that there also, unfortunately, was siren, and we're going to work with them to try to see if we can fix this. But there are 11 selections, but in siren, they only allow 8 selections to be displayed at once. And there's a little sort of icon here where you have to click to get the rest of the list. So just remember that for the step 2, there are a couple more selections on the second page, okay? And then the last is step 3, so major traumatic mechanism identified. So none or the major mechanisms. The second part is to actually identify the intervention that you've done for the major trauma patient. This definitely helps because it gives us an idea of what interventions are being done, what education is needed, and it helps us correlate whether or not, we did something that was needed for the patient when it's identified later. So, for example, if at hospital they noted that this was a very unstable pelvis fracture, when we get the patient outcome data, we'll go back and look at, well, was a pelvic binder applied during that time, right? If the patient was shock, hypoperfused, had a significant bleed, and we look at the time and sort of say, well, if it's within 3 hours of when the injury happened, did they get TXA? Then we can sort of identify this through this. So in airway, either no airway intervention was required or some sort of intervention was required. So suction, you had to place an OPA or an MPA. You had to put a supraglottic device, so like an iGel or a king tube. You had to intubate the patient, or you actually had to surgically perform a surgical airway. So that would be something that you would click off, and you'd either select none or any or all of the above. You would select either the patient required spinal motion restriction or not. So, and if they did, if it's simple or full. In terms of breathing intervention, so oxygen applied passively by nasal prongs, face mask, and BVM. If you had to assist them with ventilation, so putting a BVM on but then actively having to bag them, or putting a supraglottic device or an endotracheal tube and then having to assist their ventilations, or if you needed to perform a needle thoracostomy to decompress the tension of the thorax. And then for circulation, it's all the other interventions. So establishing either IV or IO access, providing direct pressure to the wound packing if relevant, having to tourniquet to get hemostatic control, putting a pelvic binder on, giving TXA. And then unfortunately the same thing. There's 2 other ones that are interventions for trauma, so giving IV crystalloid and then blood transfusions. As you know, we've started to introduce blood in the pre-hospital environment now just recently. So again, there's a second page for the last 2 options. So going back to the trauma case, this patient met major trauma criteria. So after selecting yes, you would be routed to the form, which needs to be filled in. So you fill in a date and a time. The patient met physiological criteria, so yes. And then major trauma or major traumatic injury is suspected. We suspected an unstable pelvic fracture in this person or this patient. And there was also a major mechanism. So with the rollover, there was a significant intrusion to the actual car itself. And then in terms of interventions, the patient was protecting his own airway. So none in terms of actual airway intervention. They were placed in full spinal motion restriction. They were applied oxygen for their hypoxia. And then an IV was started. Pelvic binder placed. TXA was given. And a fluid bolus was given. And so that's all you would have to do for your documentation. And just this alone gives us almost pretty much all the data we need to sort of evaluate our system performance. So it's actually that simple. But if you can imagine in the previous sort of handwritten PCRs and without a documentation form like this, trying to tease out this information is really, really, really difficult. So I want to talk a little bit about data reporting and then how this is relevant to you. So the purpose for this as a system is that we get these metrics and we're able to identify key performance indicators for our trauma system and how it works. But from I guess a more patient-centered and practical aspect, this data will drive guideline revision. So it will drive if more resources need to be placed for certain areas of the province, if drive times for certain things are too long, if anything like that. This is what will drive that discussion and drive those decisions. At the same time, if we're realizing that there's a lot of interventions that are happening that require follow-up, then this is a good chance for us to do practice updates in education. So if we realize, again, like with follow-up data that we're missing, 20% of patients who have unstable pelvic fractures aren't getting sort of their pelvis bound, then that's a really important thing for education and practice updates, right? If 20% of patients who are eligible and should be receiving TXA aren't getting TXA, then that's another sort of opportunity for education and practice updates. And ultimately what we really want to do is, because once we have this data, we want to consolidate it so that paramedics, for you guys, when you guys put the effort into actually put the data and take that time to do it, we want to give you guys the individual reports. So once the two cohorts are linked and once we have the outcomes, then we can easily then populate for each paramedic or each station or region all the major trauma patients within either that paramedic, that region, or that unit, and then plug out sort of the outcomes. And then you would get a copy of that so you would know what would happen or what happens to your patient. Now, at the beginning, this was going to be slow. And so, previously the way that this was done, we had probably about a year sort of delay before we actually got back data. But now if we can actually identify the two cohorts and actually link them, this will happen more real time. So we're talking along the lines of like months. So it will be a big thing. It's a work in progress, but I think the feedback, if we can get this up and running, will be huge. So that's it. So just a summary of what we talked about. So we kind of reviewed the basic trauma principles. We looked at the trauma triage and destination guidelines that are new and just reviewed them. We talked about the SIREN documentation that's now in place. And we explained what the use of collecting this data and how we're going to feed it back to you in the very end. So just a couple things, because a lot of work has been put into this. So a lot of thanks to the entire clinical and medical programs group, specifically also to the paramedic practice leaders and the paramedic practice educators. A huge thank you to Trauma Services BC and PHSA and all the health authorities, because none of this would have happened if everyone didn't put the effort and, had that sense of collaboration and that spirit to sort of move things forward to better our trauma system and to make our patients or to treat our patients better. So just a thank you to everybody for sure. So I leave the rest of the time for questions. And just again, any questions that you have that you can think of outside of this, you're more than welcome to email any of the regional medical directors or the paramedic practice leaders or educators. But another good spot is clinicalpractice@bchs.ca. So the paramedic practice leaders follow this email very closely. And so they will consolidate and answer questions. And if there's people who, or multiple people who ask the same question, then that would be a good thing for them to consolidate and then put out as the next sort of practice update. And there's a lot of questions for this. FYI, this is the answer. So it's also another good resource to contact for questions and clarifications. That's it. So I'll leave it up for any questions and comments. And then if there aren't any, we just have a couple of more non-trauma things just to update you on before official memos start to go out. So why don't we do this? Before we start in this room, why don't we just, anybody in the remote sites or on the WebEx have any questions?
Hi, it's Wendy Beasley in Prince George. And of course I'm at 580, so I have an interest in this, but how do you see early fixed wing activation and auto launch altering the decision-making algorithm in terms of time? And also, are we collecting any data on opportunities that we could be taking advantage of or missing?
So I'm going to go back to here. I'm just going to go back to the, if I can pull them up here, to the northern guidelines for that, because Devin, Patrick, and the entire team up in the north have actually thought that through pretty comprehensively. So there's actually a lot, and under the key triage points, and it's hard to sort of see on this, they talk about always initiating sort of early fixed wing or rotary wing sort of auto launch if they're available at that time, and that's basically because of all the sort of the prolonged transport times and distances, right? So there definitely is a role for that. Now, the actual sort of nuts and bolts details, I would leave that up to talking to your regional medical director and your regional paramedic practice educator or leaders for, just because they're going to have a better understanding of the nuts and bolts of that area than I will. So I think that's my short answer to that. Is there any, just in the room here, because we have Oli, John, and Joe here, I think Oli has a couple of comments about that as well.
Hey, Wendy. Sorry, I'm dealing with a cold here. But no, that's a great question, and it's a really important question, and it's something actually we've never really been able to answer in the past. But what's great about this now, one of the real benefits of Siren is that the CAD data is linked to every call. So auto launch is initiated based on an MPDS code, right? So we'll be able to tell when those codes are actually tied with the major trauma because of this major trauma form. So we'll know if it meets auto launch criteria or early fixed wing launch. We'll know if that we're over triaging or under triaging with it, and then we'll be able to, of course, make resource allocation decisions based on that data. So I guess the short answer is we'll know if it's an auto launch on the CAD data, and we'll be able to tie it directly to the patient information that we get on show up and see that patient.
Yeah, and on top of that, in the actual PDF document, we actually list out the current auto launch criteria in terms of all the event codes, and then we've revamped the early fixed wing launch criteria to actually match the major trauma criteria as well. There's also something in there. Great question.
Thank you.
Anybody else from the remote sites before we move to here in the lecture theater? Okay, questions here?
It's Ron Straits. This is amazing what you put into this.
Oh, before you do that, can you push the mic so everyone else can hear you?
Is that better?
Yeah, I think so. There's a red light, I think, right? There you go. Yep, you're good.
This is amazing the amount of work we put into this. I'm very impressed. My only concern would be we've got a handful of people here. How are we ensuring all the paramedics in the province are going to appreciate all this? And in fact, maybe even played with a call or done something, because we don't even do that many serious traumas for a paramedic in this province. Yet we need to be very efficient with this. So how is that ensured?
So we kind of illustrated this in Appendix H in this document because we knew that this was going to be a difficult thing. The communication strategy is probably the most difficult part of this project, and it's still ongoing. The good news is that we actually just recently on Monday actually got funding and sort of resources from an external sort of, I think it's Canadian Health. I can't remember. It's one of the. It's like a quality improvement and quality assurance sort of national agency that has a program where you submit projects to, and they provide sort of expertise, linking in sort of people who have expertise maybe in other areas, but can use problem-solving strategies into sort of something like a project like this, right? So we just got approved and also accepted into that program. So that will sort of help us with kind of at least. Working out sort of nuts and bolts that we can't figure out internally, but for the most part, it's a two-pronged approach. The first part is sort of all the stuff that we've done already, trying to communicate it. So rounds today, Hopefully the rounds then will be posted onto the operations page so then people can see it there as well. The communications through the updates or the clinical practice updates, your Snapchat stuff. So that's and then everything being available on the handbook itself, right? So there's the online and sort of passive component to it, and then there's the active component to it. So, and that's the role of the paramedic practice educators, potentially the practice leaders for us as medical directors, is actually just go out to the field and just actually have chats with people. So I think word of mouth is a big thing because we've got both sort of full-time and part-time and regular sort of staff, and not everybody checks their emails, not everybody sort of follows up on things. So, I think moving forward, I think we realize with this project that, we can come up with something like this, but after coming up with something like this, to put it into play and operationalize on it is still a challenge. So I'm hoping that, as we work towards this, and especially with sort of the expertise now that we have externally, that we'll find a better way, not only for just trauma, but let's say something comes up for stroke or for STEMI or something like that, that will have an even better sort of communication strategy.
Thank you. And maybe this is for Joe too. So that means the Joe paramedic in this province or Deborah paramedic in this province, how do I know that she's actually listened to this? How am I going to know that I've done this for this? Do they have a way of filling out a form or whatever online saying, yes, I viewed this and I have an appreciation of what's going on?
I think the short answer to that is no. And I don't think we have at least not short-term wise, we haven't identified a way to actually I don't want to use the words like hold people accountable, but to have people actually sort of look through the guidelines. That we haven't found an actual way to do that yet.
I would hate to think that somebody's life is impacted by their not watching this information, not learning this information. To me, it's that important. I think there should be some accountability.
Yeah, and I guess the continual message, I guess, is that we want people to use the BCEHS handbook and the app, because that is the repository for truth for the service now. That's the most up-to-date sort of guidelines that we have in the service. It's better. It's different than what we had before, where we had that one PDF document that would get updated intermittently or like annually or biannually or whatever. This is now sort of, if something is new, it gets updated right away. So I think the encouragement is to look at the app and to follow the communications that come out. Anything else from the PPL group? Or
I think Ron makes a great point, is that we don't have a great way of practice or to make sure that paramedics are being held accountable to all the nature practice. But with the BCEHS handbook now, we do have flags on there now saying that's pretty cool. So that the law will know that they're in the practice of the grant, hopefully gets compliance that way. The paramedic and specialist and dispatch are also synced on a lot of these events, so they're able to put in place the responding crews in the rural areas and more responding times, which is helpful, but again, not completely reliable. So the possible.
And one of the ways to actually, I think one of the ways that we're looking now to actually improve, I guess, information sharing kind of passively is through Siren. So when, for example, you have to answer that question, does this patient meet major trauma every single time you do a PCR, and then in the future potentially get feedback from it, it kind of also acts as a bit of a stopgap. To make sure that people are on the ball, right? Because they'll get a report at some point, or they'll look at that question and sort of think, actually, what is major trauma? I don't actually know. Maybe I should go back and take a look and see if this patient actually meets major trauma criteria. So Siren itself has been a great tool to help us, kind of bridge us towards that. And it is a bit, a system where we are in sort of the infancy of it. So there are some, it can be potentially a little bit sort of cumbersome in terms of, inputting things twice or something along those lines, but we're trying to do our best to try to eliminate all those redundancies, but at the same time trying to make sure that we get all the information that we need.
Two updates, Wilson. First one is that learning is coming up with a curriculum for an annual update date for all staff, and feel their thunder that that should be coming out shortly. And part of that day of training will be updates and major changes. So that's great. I think that annually a focus day that everybody can learn some changes, treatment guidelines, policy procedure, skill. So more information on that soon. The next thing is kind of a validation of what you said about how important it is.
Yeah, thank you.
Can you please activate the microphone, please?
Yeah, it is. Hello, hello. Sorry. So I'll get a little closer. Again, not wanting to be a spoiler alert, but we've got some research going on right now using our PSIS and Siren data and also the TSBC outcome data to the use of TXA. So we did a retrospective review of 100 cases, 100 patients that should have got TXA because of their physiological parameters as well as their injuries. And then we looked back to see if paramedics administered TXA correctly, PCP, ACP, CCP. And surprisingly, we found that I think only about 30% of the patients who should have got TXA actually did get TXA. So again, spoiler alert, this is coming out for publication, so we'll see this shortly. But the great thing about this data is now we can recognize that internally we have a problem. We have either an educational problem where paramedics aren't receiving the education that they should be giving these interventions. We have maybe a communication problem, maybe some structure problem. So the data collection part is so critically important. And I think when the paramedics are going through Siren and you're frustrated that there's another mandatory, and the paramedic practice leaders are ultimately responsible for determining whether those are mandatories or not. So it's paramedics driving the paramedic practice. It's not some administrator that's doing it for data collection purposes. We actually have our leaders here making those clinical decisions. It's because we really desperately need that information, not only for the continuation of patient care when the PCR goes into the health system and the physicians, perhaps partners down the road need that information, but importantly for our system to get better. So you've seen the clinical practice at BCEHS.ca email. If there's something in the Siren that's completely frustrating to you, or there's an impression code you think is missing, or you're just challenging why you have to do something, just send them something off to that email, and we'll get back to you and either explain why we're actually acting or asking for that information, or maybe we'll say, hey, you're right, we probably don't need that, or we do need to add something. So we've got a way to provide feedback.
Perfect. And I think we had one more question.
No, I just wanted to...
Oh, Oli first.
Oh, sorry.
No, Oli first. Nope, you go.
Zach Clarkson here in Vancouver. Just going back towards that Siren documentation portion, I noticed it walks you through sort of that step 1, step 2, step 3, which all looks like it, fairly intuitive and makes sense. But is there a formal process for capturing those step 4 special consideration patients who we identify as needing to go to a leading trauma hospital and we take them there, and that may end up on the Trauma Services BC registry? Or are we going to capture those so it doesn't look like we're under triaging those patients?
The short answer is no. And the reason for that is because there's a huge amount of variation in one practice depending on the patient population. And it's hard to objectify those things sometimes. So most systems, almost all systems, have stuck to step 1, step 2, step 3 as their definition for major trauma. So we're going to start with that. Okay. I think rather than a huge, starting with something that's really huge and trying to tease out a lot of things at once, we stick to sort of the basics at the very beginning. So major trauma patients, step 1, step 2, step 3, evaluate that first. And then once we sort of realize, if something doesn't match and we realize that that's related to step 4, then maybe that can be something that's introduced in the future. But right now, no, we're just going to keep it simple as step 1, step 2, step 3.
Sure, fair enough.
And Lance.
A quick question, Lance Stevenson from Vancouver Island. A couple of things. First of all, the different trauma facilities levels of trauma. You get level 1, level 2, and level 3. Is that it's somewhere in the document?
Yes. So that's here. So that's in the lead trauma.
Definitions.
They're actually available on Trauma Services BC.
Okay.
So
I often get asked about that. We understand what level 1 trauma center is, but beyond that, what does it make to level 2, level 3?
I think it's actually also outlined in one of the Trauma Association of Canada documents as well. So I'll send you a link about it.
Would it be worth having just a small definition in our guidelines?
Okay. Nope. Sounds like a plan. I think what we're going to do is once this is going to be updated continually. So there's also been a couple of small sort of suggestions like this that have been put forward. So I'll add it to the list. So then the next iteration we'll put an update for that.
Okay, great. I might be dating myself on this, but some time ago, You had mentioned within your talk about warming the trauma patient and warming your fluids. And yet there was a study quite a while ago about cooling patients, especially with head injuries. And this might have been before TSX. I'm just wondering, was there any further research around that, or did that ever materialize? I know there was a case out of Mexico that ended up in the States. The patient was put into a hypothermic state and did much better post-head injury than they had found patients that were normal temperature or higher temperatures.
So I think that the general comment to this is that cold in a trauma patient is bad. So the exception or potential exception that mainly on a case-by-case basis, if it's an isolated head injury, there may be some consideration for it. In a polytrauma patient, cold is bad, right? So coagulopathy, acidosis, all that sort of stuff, that's all related to the patient being cold. So I would err on the side of actually warming the patient in that sense. Okay. If there's any sort of questions about any of this, I mean, again, resource would be clinical or EPOS if you're not really 100% sure, but I think almost in all cases, you want to be warming the patient. Yeah.
Andre from Vancouver. So going back to the regional differences here, so take Fraser Health as an example. Is there any consideration for the services level 1 versus level 3, both being trauma receiving? So for example, the case I'm thinking is a head injury closer to that is for which may be neurosurgical services.
Mm-hmm.
Is it an early EPOS phone call and start driving towards Columbia, or how's that?
So it's actually that exact scenario is actually in the guidelines themselves. So if you actually look, it says for patients with suspected neurosurgical injury, transport to RCH of less than an hour. So there are certain regional things that have been identified that have been sort of issues in the past, and so the regional guidelines actually usually encompass all of this. So there's a provincial kind of standard kind of framework or guidance of how to think about major trauma, so that if you don't know, just go by the kind of the standard protocol. But if you know and you know what your region is sort of like in the specific nuances of your region, then you'll follow the regional guidelines for all of that sort of stuff. Yeah. And in terms of level 1 or level 3, I think the idea is that we want to put all lead trauma hospitals on the same playing field. So we want to recognize that lead trauma hospitals are all capable of managing trauma patients. So regardless if it's level 1, level 2, level 3, that sort of thing, they are the lead trauma hospital or the center of trauma expertise for that region of the province. So we don't really want to delineate or sort of compare level 1 to level 3 in that sense. They are still providing good and quality trauma care.
Quick question, Wilson, and it's always a hard one, and I don't think we do it very accurately in our handbook or guidelines about the definition of pediatric patient. And I know we have had this recently where you've got a 16-year-old, 200-pound kid who's stabbed or run over. Do they go to children's or do they go to BCEHS?
It's a hard question, and I think, in this case, I mean, the child was brought to BCEHS, right? If you look at the actual coastal guidelines, they describe it all being greater or equal to 16, and then pediatric being less than 16. So that's the formal age cutoff. But I mean, 13-year-olds, if you don't know how, they could look like they're 17, 18, 19-year-olds, right? So again, this is the age there is more there for kind of like administratively there needs to be an age. But at the end of the day, it's your judgment. I think that's we can sort of debate this to the ends of the earth to sort of say, when does a pediatric patient start exhibiting sort of adult physiology and therefore need to be sort of treated more as an adult than they are as a pediatric patient. And that varies in terms of various conditions. So it's not just trauma, but like other things. It's like, is it 14? Is it 15? Is it 16? Is it 17? Right? So it's written as 16 in these documents. The documentation here is deliberately vague in terms of setting an arbitrary age cutoff for pediatrics for the entire province because it will potentially vary within the system. But at the end of the day, all lead trauma hospitals, fortunately, with the exception of BCEHS and children's, are both adult and pediatric receiving centers. So that probably should, you know, from an operational side of thing, not really be too relevant, with the exception of down here in the Lower Mainland. But then again, your judgment.
What about secondary sexual characteristics? Should we go with that?
I don't know. It's opening up a can of worms. I think we could probably have like an hour discussion about this. So, you know, I leave this up to sort of the pediatrics, or like the pediatricians and the pediatric surgeons to sort of, you know, really determine what they want. And in our discussions with them, we've decided to sort of keep it, 16 here, but, you know, there is a bit of gray area to it. Yeah.
Two things I just wanted to sort of follow up on what Monica talked about earlier and ask you a question following that. But we recognize that not everybody is following the app or checking their email, or it's, you know, tied into technology as everyone, you know, could be. But I think there's a lot of good work that's being done by the practice educators out there throughout the province, delivering the messages like this that come out, and they're actively getting out to as many of these stations as they can, as we are too as practice leaders. But I just wanted to say that this is because of the work that you did, actually, for free for many years. And I remember you made a point of getting out into the field, delivering these messages, because you knew the value of the face-to-face contact with the education. So we've sort of formalized that, and that's the one. So not quite as good as what you were doing for 3 years ago, but we've got more. And my question was, for Wilson, what do you estimate, or I know it's probably no real answer, but we've got VHA and we've got interior health, and those are two big areas of our province that have blank white patients paper. We're actively working towards getting those guidelines and something hopefully soon.
Yeah, I think I don't want to speak out of turn, so I'll just leave it as they should be coming within the next couple of months. So I don't want to don't want to steal anybody's thunder, and don't want to put words in anybody's mouth. So from what I've been told and sort of how things are progressing, probably within a couple of months. Yeah. So you'll see updates, or you'll see something when those algorithms come up to let you know that that those guidelines will be there. Cool. So without any other questions, I want to thank everybody for their time. And again, if you have any questions, feel free to reach out to any of us. So thanks again, and have a great day.